Doctor, isn't that true of any clinical trial? Some get the treatment and some don't. Some get the diagnosis, some...
In terms of being able to attract a sufficient number of patients to the trial, and in terms of being able to get them to accept a randomization by flip of the coin to whether they would or would not get mammography, I have, and I believe others have, serious concerns that that kind of trial could not effectively be carried out in a reasonable period of time to get a conclusive answer to the question. While in the meantime, where we believe we should be focusing our efforts is in even better methods of detection than mammography, and to look at newer technologies and their applications in the kind of clinical trials you're describing.
Senator Harkin.
Thank you, Senator Mikulski. Well, I've looked very carefully at the study that was done by Olson and Getze. I don't know if that's the way you pronounce his last name, Getze. I believe that's it. And it seems to me that they, first of all, as you pointed out, these were mammographies that were done in the 1960s and 70s, maybe early 80s. I don't know if it got into the 80s or not, but sometime in that time frame. And as you stated, we clearly have a better mammography right now, technologies than we had at that time. Secondly, Olson and Getze also, as I understand it, looked at the technical details of how the studies were set up.
Correct.
And if I'm not mistaken, that NCI or others have looked at this and basically refuted some of their findings based upon what happened later on. I'm sorry, this is a layman speaking here, not a doctor, not a biostatistician or anything like that. But it seems to me, as I read through it, that Olson and Getze looked at, let me put it in layman's terms, looked at one part of the studies. Based upon that, they said there was not conclusive evidence. They didn't really look at everything in all of the studies that were done. At least that's my layman's way of interpreting it. And based upon some statistical analysis they had done about how the groups were selected and who was screened and who was not screened,
correct,
they reached these decisions. But they didn't go on later on to find out that those were adjusted for, if I'm not mistaken, later on. Those anomalies, whatever they might have been, were adjusted for later on. Am I somewhat correct in that?
Yes, Senator, you're quite on track with regard to your interpretation, as I also see it. And I believe in the next panel there will be experts far more sophisticated than I with regard to biostatistics, but I am in agreement with your interpretation.
I know this, to the general public, this sounds like a lot of gobbledygook, and it's sometimes beyond my comprehension too, but if you read it and really get into it, I think I'm finding out that that they just look too narrowly at the studies. And secondly, not taking into account the new technologies we have and the development of better mammography screening that we have today.
At the core of today's hearing is a controversy about the efficacy of mammography and screening. Stepping aside from that, is the advice that you're giving to women today to continue the screening, is there other advice you might give in terms of perhaps starting younger in terms of screening, or a different approach to it that would avoid this question of the efficacy of the test and the statistical debate we're having today?
No, Senator. I think that we've set the threshold at 40 as what we believe to be the optimal or reasonable level at which we can recommend it and apply it. Now, again, the research that I alluded to earlier in terms of understanding the disease will hopefully lead us to be able to identify women that are at much higher risk than normal or average. And in those women, we may need to modify or change the recommendations as we go forward so we could detect them even sooner or earlier. But that is a work in progress and not yet reached the point where we can make it a uniform recommendation.
Now, you have experience on several different medical conditions, cancer, et cetera. Is there similar controversy in other areas, for example, in terms of prostate cancer or other cancers, where the testing regime and the efficacy and the efficiency are also debated as they are with mammography?
Yes, sir. Unfortunately, there is, and I personally was deeply involved in the issue of formulating guidelines for men for the use of prostate-specific antigen. And as with mammography, in that situation, there's even less data or information upon which to make hard, specific scientific recommendations. But I think what we are faced with as clinicians responsible for the lives of patients with cancer is to apply the science, but then at the same time use clinical judgment and arrive at the best recommendation we can today, given the information that we have. The information in mammography is far better than the information for PSA and prostate cancer. And we are basing a recommendation to American women on what we have available as the best information.
But I would suspect that both of these areas have helped in terms of your analysis by having experience in several different fields has helped inform your judgment about your recommendation today.
Well, what's most gratifying to you and to us is the fact that in both these diseases we are seeing a decline in mortality. We are seeing a decline in death rate. And that gives us hope and a bit of comfort that we're at least on the right track. We're nowhere near where we need to be, but we're heading in the right direction.
Finally, Doctor, you indicated in your testimony the disparity between the incidence of breast cancer in African American women and in white women, Caucasian women. What role does mammography play in this disparity, and what might be other contributing factors?
Well, there are two very interesting observations that can provide or shed some light on the answer to that question. One is we are beginning to see the gap narrow between the mortality rate from black women and white women. So we're improving, we're closing that gap, and we're making progress. And that coincides with the fact that there has been greater utilization of mammography among black women. So hopefully those are coincident. I cannot prove them to be cause and effect, but they are coincident, and they are both encouraging.
Mary?
Thank you very much, Madam Chairman. First of all, for having this hearing, which I think is so important today, but for your long time work on the issue of breast cancer. And we've been here before debating this issue. Senator Hutchinson remembers, and frankly, we've been through it too many times. And I think the bottom line is women need to know what they can do to fight breast cancer. And unfortunately, this debate too often comes down to a debate between numbers versus women. And we've allowed abstract statistical data to confuse and distort the issues. So I want to thank all of the witnesses who are here today, especially the advocates, for the tremendous work that you do on behalf of many women, and appreciate your continuing efforts to make sure that women have access to early screening and diagnosis. Madam Chairman, it just seems to me, unfortunately, that we have allowed this controversy to shift the focus away from prevention and access to health care. This isn't just an issue for women who are in their 40s or 50s, but for women who are in their 20s and their 30s who want to know what they can do today to prevent breast cancer. And I hope we don't lose our focus on that issue. And one of the issues that concerns me a lot is that we do know through better information and access, more women are getting regular mammograms, and we know that has helped to boost survival rates. But we also know that access hasn't improved equally across the board for all women. Minority women have a much lower screening rate. In fact, the screening rate for Asian and Native American women really is dismal. And I know there's a lot of factors that contribute to those low rates, but I am very worried that the current conflicting and confusing messages aren't going to help our efforts to expand access. Doctor, if you can just tell me what you think we need to do to make sure that this current controversy doesn't hinder our efforts to improve access for minority women, I would appreciate hearing your thoughts on that.
Thank you, Senator. We have tried to be very clear in our message so that we did not continue to contribute to some of the concern. At the same time, we are paying a great deal of attention within the National Cancer Institute, particularly through Dr. Reimer's division, regarding messages and communication and education, so that patients do in fact have appropriate and timely and accurate information. And we're learning and studying how to reach out as effectively as we possibly can to varying communities so that we can provide that appropriate message.